Oh, it's 45. Okay, good afternoon and welcome to this session. Today we're very excited about it. I'm going to do brief introductions, sort of outline how we'd like to structure this today, introduce our distinguished group of panelists, and then hopefully have a great discussion over the next hour, very interesting discussion over the next hour about DCD NRP. For transplant donors and recipients, and some of the ethical dilemmas around it. My name is James Anton. I am a cardiac anesthesiologist in practice at the Texas Heart Institute and Baylor College of Medicine in Houston, Texas, which has been my home for the last 23 years. My other panelists, Jenny Nye. Jenny is Associate Professor and Chief of Cardiac Anesthesia at New York University Langone Health Center. She's also the director of the Cardiac Thoracic Anesthesia Fellowship, the director of cardiac and lung transplant anesthesiology, so she's got multiple administrative roles, and she's deeply involved in transplantation, as you can tell, and this is a passion of hers, and she does a lot of this at her center, so we're going to be leaning on her a lot today. Our next panelist is Bruce Betcher. Bruce is an associate professor of anesthesiology at the Medical College of Wisconsin. He has with a focus in adult and cardiothoracic transplant anesthesiology. He's the medical director of transplant anesthesia for the Medical College of Wisconsin, and he serves as the director of the Adult Cardiothoracic Anesthesia Fellowship there. His focus is "quote unquote" liver transplant, but he does all of it. So he'll be a very active part of this as well. And finally, Teresa Galzinis is a professor at the University of Pittsburgh Department of Anesthesiology and Perioperative Medicine in my hometown, Pittsburgh, Pennsylvania. She's also very active in resident education and part of their transplant team and part of our panel as well. So I want to thank them for being here today. This was the brainchild of Jenny, so I want to thank Jenny. I want to thank the organizers for accepting this. Even though it was submitted as something different than it turned out to be, we still got in, and we're gonna make it work. So just briefly, I want to sort of outline how this is going to go. So Teresa's going to come up, and she put together just an introduction to the topic, brief 5-10 minute introduction to the topic, and then this is really intended to be a conversation. So really hope we'll be asking for your participation. It's much better as a conversation than us sitting up here talking about the ethical principles around, donation and some of these practical issues. So we really want it to be a conversation. The front of the room is very open, so I'd encourage you to move up so we can have a better conversation if you want. But that's really how it's going to go today, and hopefully, it'll go fast. We sort of mocked it up, and in 45 minutes flew by. So we're excited about it. Before we start, I just want to poll the audience just to give a panelist some idea of who we're talking to and why. So who is involved in either donor or recipient transplant care? Okay, so 80% of the audience? Great. Who would consider themselves a large donor center or a donor, whatever has a donor center or high volume donor center? Of those people with their hands raised, who is doing NRP for your DCD donors? Okay, so a smaller number of people. Anybody from Europe? Because obviously their experience is very different than the United States. So do we have anybody from Europe who's involved in NRP in the audience today? All right, fine, but maybe we'll get somebody down the road. Okay, so that helps us a little bit. Thanks all for your cooperation, and again, really looking forward to it. So I want to introduce Teresa. She's going to come up and give us a brief introduction to the topic and some of the things we're going to talk about today.
Although looking at most of you with your hands raised, you're not going to a lot of this is going to be a review. So good afternoon. I'd like to thank the organizers for inviting us to speak. This is a session. It's not a panel on should we or shouldn't we, the ethical dilemma of DCD and NRP. None of us have any disclosures, but we were all happy to get any if anybody's interested. So instead of a lecture, we designed this session to be a place where questions and concerns about DCD and NRP can be discussed. So actually, you already gave my line, so we're going to go on. All right. So why do we care about DCD? Looking over the years, the percentage of DCD organ donations has increased substantially, and in the U.S., it makes up about 43% of our donors. Now, what is the other problem is on July 20th, the New York Times wrote an article that reduced the number of potential donations in the U.S. This article describes instances where DCD donors had either physiologic reflexes or signs of life, either prior to or during donation, and in some instances, there was a question of consent. Now, in most of these cases, the donors died, or the potential donors died, but in two, which are in both of these articles, they survived intact. A follow-up article by the New York Times documented 73 cases of questionable DCD donations since 2019. Now, that seems a lot, but over that same period, there were over 25,000 DCD donations. But even though this number is small, even one is too many. This led to a mass exodus of people removing themselves from the donor registry in fear that their organs would be harvested while they were still alive. So let me go over the OPOs. So they're not for profit, although everybody knows I work for a big place that's not for profit and they make a lot of profit. It's responsible for recovering organs from deceased donors for transplant. There are 55 in the U.S., although now there's 54. They assess donor potential, they convey clinical information, and they follow policies for offering organs. They work directly with the donor families to discuss donation, and they facilitate authorization, they test, they provide organ recovery and delivery of the organs to the transplant hospital. Now, the OPTN matches the donors and recipients, and they're managed by the United Network for Organ Sharing, and all the OPOs use OPTN. Now, the question is oversight. The OPOs are certified by the Centers for Medicare and Medicaid Services. There's also state regulations and industry accreditation requirements. And actually, there is a specific number of donors that they need to process to maintain their certification. And this is where some of the problems show up with. Okay, why isn't this going? There we go. So another result from the New York Times articles led to the U.S. Department of Health and Human Services stepping in to examine the practices of these OPOs. RFK Jr. actually looked to see with each problem to see the OPO to see if they meet the standards that are set by CMS. And they actually closed one. So the 55 is now 54. The ASA also has a statement on controlled organ donation after circulatory death. They used the Uniform Determination of Death Act as its definition, which is the irreversible cessation of circulatory and respiratory functions, or the irreversible cessation of all functions of the entire brain, including the brainstem. And they didn't have a specific protocol for defining death. It is left open, and it's a determination of death must be made in accordance with the accepted medical standards. In 2006, there was a national conference that looked at donation after circulatory death, and that is where they get their irreversibility definition. So irreversibility is recognized by persistent cessation of function during an appropriate period of observation. Based on cardiopulmonary criteria, death occurs when respiration and circulation, not cardiac, but circulation has ceased and cardiopulmonary function will not resume spontaneously. So let's talk about DCD donation. So in 2024, there were about 7,300 DCD donors. What DCD is, it's death due to irreversible loss of circulatory and respiratory function. So these patients usually have either some kind of high spinal cord injury or some catastrophic neurologic injury, but they do not meet the criteria for brain death, and they require life-supportive measures to stay alive. So the first step in donation is a determination by the patient's physician, the ICU physician, that further respiratory and circulatory life support is futile. Then there's an opinion that care should be withdrawn. Only after that can the OPO talk to the donor's family. So what is the process for all that you not know? The ICU care team is responsible for OR care and CMO management. So in the OR go the ICU physicians, nurses, respiratory therapists, even their ventilator and their monitors are ICU. Typical CMO medications that are administered are anywhere from midazolam, propofol, or opioids. No muscle relaxant is given. The donor is prepped and draped, heparin is administered, the family is brought into the OR, then there's extubation by the OR team. So no surgeon or no OPO or no anesthesia is in that room. When the donor expires, the ICU physician declares time of death, and depending on the organ, the donor needs to expire in up to 2 hours. If for lungs, it is 90 minutes. If not, the donor is brought back to the ICU to pass there. Once the time of death is declared, there's a standoff period for about 2 to 5 minutes to make sure there's no return of spontaneous circulation. Then the ICU staff leave and the organ donation comes in. And we're usually involved when there's a lung or a heart harvest for reintubation, bronchoscopy, and circulatory support. So when the hearts are being donated, there needs to be a period of reperfusion. There's the heart in the box, called organ care system, or ex vivo, which is normothermic regional perfusion. And the type depends on the organs that are being obtained. If it's abdominal organs, the descending thoracic aorta is clamped, and then the rest of the organs are reperfused. With thoracoabdominal NRP, those are the thoracic organs, and anesthesia personnel is involved. With NRP, there is a sternotomy. The donor is placed on mechanical circulatory support. The carotid and the vertebral arteries are clamped. There's reintubation and ventilation. The donor is reperfused for up to 45 minutes, and then there's an evaluation of a donor heart. The concerns about TA-NRP, is it violating the dead donor rule, which means donation should not lead to the death of the donor. So if putting them on NRP, does it reanimate them? Does it make them alive again? How are we certain that there is no blood flow to the brain? How are we certain that there's no neurologic function? And what about the moral distress from the providers? I don't know about the rest of my panelists, but the first time I did this, it was a very strange and surreal experience. In fact, in transplantation, Murphy et al. Actually looked at these ethical issues and found that among providers, there is no consensus about the ethics of doing NRP. But there's something new on the horizon. In July, this case report was actually published in the New England Journal of Medicine that showed a procedure that could actually reanimate hearts without reanimating the body. Here, before the patient was extubated, there was a circuit that was flushed with an NRP cooler and heater. Basically, what this does is it gives oxygenated cardioplegia and blood to the circuit, and so the heart is oxygenated, it is cooled, and it is given nutrients. And then instead of having the carotids clamped, they clamp the ascending aorta where they would clamp it as a regular cardiac case. So the solution is made of red cells, cardioplegia, heparin, mannitol, rocuronium, salumedrol, and levothyroxine. They oxygenate the solution. The solution has a pH of 7.5, a bicarb of 30, and a PaO2 of greater than 500. And their flush temperature was 4 degrees centimeters. So after a 5-minute standoff, there's sternotomy. Then there's the aortic cross clamp in the ascending aorta, so there's no brain perfusion. Then the flush is slowly placed into the donor heart, keeping a mean map of 80 millimeters over 12 minutes, and then they perform the cardiectomy, then in the cooler for transport. They performed this on 3 patients, were all transplanted and did well, and it avoids NRP and all the ethics. And that's all I want to say. We're going to ask you some questions, and we would like you to ask us questions. Do you guys have any thoughts about any NRP? Yep, come on.
Okay, well, I'm going to ask the panelists some questions. So I'm going to put them on the spot, and hopefully it'll provoke some good conversation. So I think the first thing, so this is about ethics, but I think the first, just to frame the conversation accurately, there has to be a conversation about outcome, I think, and so we're going to focus by organ. So I'm just going to go straight down, and obviously this is shaped by their personal experience at their centers, but I want to hear Jenny, Bruce, Teresa, for your respective quote-unquote organs, if you're using NRP, how have your outcomes been? How are your surgeons feeling about it? So I'll start with me, even though not on the panel. We are not using NRP at all in our hospital for donors because we are a joint venture partner with Common Spirit Health, which is a Catholic-based health organization. And so they have not reconciled the ethical issues, some of which Teresa already mentioned, to their satisfaction. So we're not actually doing any NRP donor at all. We are using selective NRP donors for some of our recipients, although the surgeons have been very conservative about it because they are getting pushback even on that piece of it. I think ethically, and then there's some logistical stuff as well. Our donor surgeons don't like NRP. Our experience has been positive with our hearts and our livers in terms of outcome. Our lung surgeon has outright said he does not want to use NRP for the lungs anymore. He has not been impressed with it. He actually thinks our outcomes are worse with NRP, to the point where when there's an offer and the liver is part of the offer, he's asking the question before he even accepts the offer, whether NRP is part of the plan or not, because he is not a fan for the lung. So with that, I'll sort of turn it over to Jenny, donor and recipient sort of experience that you're at NYU.
Right. So for us at NYU, we have been doing the NRP for a while now. I think we did our first one in 2020. Our surgeons were big proponents of doing it, so we started it very early. And our outcomes for the recipients that had the NRP organs are very good. They're comparable to DBD. So we have not had any real issues. We actually started off doing the DCD NRP procurement first at our hospital as well, and then moving them to like the neighboring OR. And doing it that way. And just recently, in the past couple of years, we've started using NRP organs from other places as well. But have not had any issues in terms of outcomes for our recipients.
So at Medical College Wisconsin, we haven't been doing NRP donors for as long, but we've have been doing them as well, and have not. We've not had any issues with recipients from those. As far as liver transplants go, we use NRP very frequently for DCD donors. The data for liver transplants is probably the strongest from an NRP standpoint. They are able to actually use about twice as many organs as compared to just regular DCD donors if you're using NRP, and the outcomes are actually improved. The biliary, ischemic biliary complications are significantly lower for recipients who have a NRP liver. I wouldn't say our surgeons are quite to that point, but I have heard rumblings that there are some liver transplant programs that will not accept the DCD organ if it's not NRP. Can't say that I personally can confirm that, but I've heard, second and third hand from different people that there's programs that are going that route just because the outcomes are that much better for DCD donors.
And for lungs, they don't like the DCD, NRP lungs at all. They won't use them. In fact, they won't even use the ex vivo lungs.
Is it clear what the issue is with NRP with the lungs, like and why they do more poorly, like just from a pathophysiologic standpoint?
It's just the fact of more volume, more reperfusion, yes.
Yeah, sorry, go ahead,
We
Teresa.
were also, if NRP is going to happen, they have no problem with doing the lungs and then doing NRP for the abdominal organs, but they don't want to bother with the lungs. They don't do as well.
Yeah, we've done a couple of NRP lungs, and the recipients tend to do okay, not as great. They tend to have more edema
Yes.
in the
Yeah.
And
the
more
lungs.
PGD.
That's what our surgeons have
So they end
described
up
to
on
us as well.
ECMO a lot of times
They
after.
come off boggy, they're wet,
Yeah.
edema is a problem. And then the PGD issue is there always. So for anybody who's involved as a donor, because I'm not, so this is actually like a genuinely curious question. Jenny, Bruce, Teresa, if you're doing it for donors, how have you reconciled some of the questions around, some of the ethical questions that Teresa raised within the hospital or within sort of your division, or, with has it been addressed formally? Or how you had those conversations, or have you had those conversations?
Well, I actually started the NRP program at Pitt, and it happened on a Saturday when I got, the surgeon found out I was on call, and he wanted me to be involved without telling me, and he said, "Oh, yeah, we have nothing." And then I walk in to doing this NRP donor with no guidance about what to do, with a respiratory therapist actually taking the oxygen off of the ventilator, our machine. So we had to quickly, once the donor passed, rehook our lines. It was a show. But with that, we actually got our OPO involved, and we literally set guidelines where what we need to do. We got extra oxygen things for the respiratory physiologist. We literally took them through step by step. Ethically or emotionally, it was very strange watching. We're out of the room, but knowing that somebody was in the operating room and dying, and then reintubating somebody that was very unsettling. It's now more, it's now easier. But yes, the first time it happens to people, I can see that it's pretty unsettling. But these are patients or donors that are not going to have a quality of life, and that they're going to be made CMO anyway.
How do you prepare the families for this? This is a lot. for
Yes.
them. And so how are they prepared and how are they supported, like, in the moment? And this is happening,
This is probably one of the bigger kind of topics that comes up when we talk about NRP. And it gets complicated because of the overlaps in care. So this is how much should be discussed with the patient's family in regards to what we're doing for these family members or loved ones of theirs to prepare them for donation. It gets a little bit complicated because for those of us who are in the OR, we're not interacting with the patient and the family beforehand. There's that separation. But I think a good point that's brought up in a lot of these discussions are, remember, most of these folks, they want to donate their organs. All of them do. They sign up to donate their organs, right? So for myself, I'm an organ donor because I feel like if it's not going to do me any good, I want it to help somebody else, right? And that for our families is an important thing, that they realize that despite the fact that they might be losing a loved one, they're making a donation that's helping someone else. And so you can't go through all of the technical details because that's enough that we could talk just on the technical parts of NRP for the next hour. But discussing with the family how the process works so they understand that, I think, in my opinion, is an important part of this. But most families, at least from the experience we've had, seem to understand that this is what's going to allow them to have the best chance that their organs are going to be able to help someone else. And so I think framing in that conversation about how it's going to be processed and how come it's that way and why it's going to help their loved one donate their organs to someone else is an important part of that conversation.
I think my experience was a little bit different than Teresa's because I was present for all the discussions with the surgeons before we did this. We talked through, what we're going to do, what our parameters were, how we were going to do all this. So, like me personally, I was a little bit more prepared, and I actually did the first DCD procurement that we did at NYU. We had a place designated for the family members that they could go to right out of the OR. We made sure that the paths of, because all of this is timing, right? Because especially for us, we did the donor and the recipient in the same OR. And so we were very careful to outline paths of where the donor would, and the family members would go when the recipient was being wheeled into the room and everything, because we were very cognizant that we did not want one family's emotions to, I don't know if that's the right word, but, the other families, because obviously one's going to be very happy, one's going to be very sad. So we were very careful to think about all these things and make sure that people were taken care of to the best that we could at the time.
The interesting thing for me, so this article is great, by the way. Actually, we did this in our fellow journal club last month because this is an ongoing conversation. It's a great article and a great refresher on ethical principles as well. One of the, aside, as Bruce said, we could talk about the mechanics all day long of how it works, and this really focused just on the ethics piece of it. And one of the things that was discussed is the consent process for NRP with the donor's family or the designated, the person designated to direct that care, and the lack of consensus in the standard. So my impression is that there is no standard in terms of requirements for consent. I don't know if, again, back to the panel or back to anybody in the audience, there was a number of hands that were raised who are involved in this process for the donors. To my knowledge, there's been no consensus on the consent process and what is to be disclosed and not to be disclosed about the actual process itself. And I think that's an interesting conversation to have as a bigger sort of conversation. So again, back to anybody, I'll throw it out. Have you had those conversations around? Jenny sounds like you've had a lot of conversation about how it's going to work, but specific to consent, have you all had those conversations? Yes, please. Yeah. Yeah.
Can you come up to the microphone so everybody can hear you?
I'm from Colorado, and our OPOs do the consenting, right? And I think that's probably a national standard because the team involved should not be talking to the family. But our OPO thinks that, like, you know, the point is that the donor wants to donate, and the family doesn't need to know the gory details and be freaked out. There's Royal Papworth is doing a study about brain flow after opening the vessels, right? And so as part of their consent, they have to tell the family everything. And their experience has been that it does not bother the family, actually, and they continue to allow them to do it. So, I mean, it probably is more about what the donor wants than the details, as long as, you know, we're good stewards and we don't do stuff like cut people open that are still moving.
Yeah, you know, it's interesting. I don't remember where I was watching or reading it recently, but I think it was a Canadian kind of just informal survey of the general public when they talked about NRP, and they said, you know, is this something that you'd be in favor of? And actually, most people said no, but they said what they've seen in clinical practice is most families have no objections to it when it's discussed with them. So, you know, if you just find someone on the street when they're not in that actual situation, most people will hear it and say, well, no, I wouldn't want that for myself or my family member. But when presented with the actual situation, understanding of what's going on, most families do seem to be in support.
Yeah. I mean, I've obviously never been present for the consent process, but I've been told that our OPO does go through to some level, I don't know how much detail, about NRP with the family members. So as far as I know, like, ours do know about it.
So pivoting just a bit, I sense that abdominal NRP is very different than thoracoabdominal NRP as an experience. That's my sense.
Yeah. So, I mean,
So thoughts about that? You know, yeah.
So you mentioned looking at you know, brain blood flow, that the study, and so that's one of the things that I think there's not great data on. There's a few case reports and there's some animal studies, but when we're doing thoracic NRP, we're clamping the head vessels, but there's concern that is there some sort of collateral blood flow coming from the spinal cord, and so most of the limited data that we have is no, there is not, but it's not great. And so that's one of the things that has been discussed and is in works, is trying to get studies to actually document that. When you talk about abdominal NRP, it kind of takes that out of the picture a little bit, because now we're clamping, you know, down well below in the thoracic aorta, so there's no risk of collateral blood flow or not. And usually, unless they're doing, like Teresa had mentioned, kind of that rapid cardiac recovery, something different, they're not reperfusing the heart itself, and so it's just reperfusing the abdominal organs, and so that concern is significantly lower, it seems like, against, at least in most people's mind, when we're doing abdominal NRP versus thoracic. And so we're, from an anesthesiology standpoint, at least at my institution and most institutions, we're not involved with abdominal NRP. It's only if it's thoracic NRP that we might be asked to take care of that patient, that donor.
Please.
Lori Davies from University of Florida. So one of the things, I just want to back up just to DCD to start there, right? So one of the things I struggle with when I review the literature is it appears to me, and maybe things have standardized more, that nobody can even decide on how long you should wait to make sure that, you know, the irreversible, whatever you want to call it. So I struggle with that right from the get-go, okay? Our department, many, many decades ago, said we want nothing to do with this. I'm from the Department of Anesthesiology, so we have towed the line and said we're not going to be involved. But then we struggle, and I don't know exactly you guys' background, Teresa, if you're working in an OR or if you're the ICU doc, and Jenny, I don't know about you, and I don't know about you either. Are you guys the ICU folks who are bringing the patient to the operating room?
No.
Okay, so our surgeons evidently have talked to your surgeons, because our thoracic surgeons are, you know, the ICU brings the patient, and oftentimes, you know, they struggle with staffing as well. right? And so somebody, maybe a ARNP or something, brings them, and they extubate them, and then they all leave. And then somewhere along the line, then my thoracic surgeon calls my resident who's on call at 2 a.m. and says, come reintubate this patient. And we have been very clear that we want nothing to do with it. So the logistics of this are problematic.
Yes.
So,
Lori,
I mean, the
our experience is very
ICU needs to reintubate the patient, or they need to train respiratory therapists to reintubate the patient, or whatever the case may be. But we don't want anything to do with it either. Just so you know, I mean, it's a very controversial thing, and I just thought I'd
Agree,
throw it out there.
100% I agree. Yep.
That's why we're here.
Yes. Yeah.
Nathan Ashby from Vanderbilt. I actually run our DCD program. So I think a lot of the concern over slippery slope when it comes to the ethics here is absolutely on point and requires us to really be ahead of it. Our program is set up so that I'm an intensivist. I do not do cardiac anesthesia. I do not do liver transplant, though some of my colleagues do. But our program is set up so that we have an on-call ICU doc who is specifically designated to take the patient, not donor, patient, to the operating room for withdrawal of care. And our job there is to take care of them just like they are in the ICU, any other patient that we're withdrawing on. Except we actually keep an attending standing there at the bedside to make sure that the patient remains calm, comfortable during the dying process. And when we see that patient actually expire, then we start the diagnosis of death. We are very explicit in our consent process when we talk to the family. Our OPO talks to them about the DCD process. We don't accept that. We have that same conversation. And that includes very explicit discussion about the fact that heparin is the one and only thing that we do that helps donation. Everything else is about the patient, because in DCD, you are not a donor until you are dead. Very different from a brain dead donor. And this is something that every time I get into a conversation with people who are outside of the group, I have to beat into them over and over again. Patients in DCD are patients who would like the opportunity to become a donor. They are not donors until they actually expire. If they don't expire, they were never a donor. They go back as a patient. And I think a lot of the angst and moral concern can be at least controlled a little bit if that separation is maintained and thought of. Now, the exact opposite, our anesthesia colleagues, because they have no involvement in that dying process, do get asked to come in and reintubate the patient if we're going for lung or something like that. But generally speaking, they're not really involved that much either, because when they're surgeons are going on NRP, it's the surgeon and a perfusionist, not an anesthesiologist, with the few exceptions of when we do need them to reintubate. They have the opt-out ability if they do not feel comfortable, and we have made conscientious plans for that with backups through the hospital, so that if our first call attending in the middle of the night on a weekend does not feel comfortable participating in that reintubation, we have an ICU doc who is not the DCD doc, who is not taking care of this patient, to come down and actually reintubate as well. But it's layers on layers on layers. And the transplant folks keep coming up with new things, and we usually are struggling to kind of keep up with them. But it's a constant discussion and constant thought of how do we keep this where we are taking our care of our patient, our focus on our patient, and not a box of extra parts.
So we are very similar at NYU. We were very careful to draw the lines and have each individual have a specific role. So we have intensivists that do the ICU care and withdrawal process. And actually, we do not involve every intensivist. We have one or two intensivists that are involved in the withdrawal. And then as anesthesiologists, we are not involved. We do not come into the room, because I'm speaking like from a cardiac standpoint, when we go on bypass and all that stuff, we are not involved until after the declaration of death. And so same thing, if they do not pass and they're still a patient, they go up to the ICU. And so we are never involved with those patients.
And in my institution, we are not allowed to say we're not going to reintubate. That is considered part of our practice. Now, I have a large enough practice that if one doesn't want to intubate, there'll be somebody else to do it. But we are not allowed to refuse. The other thing that we've actually started doing is we don't do our donors at 2 a.m. so that there's plenty of, and for the cardiac NRP, it's all the cardiac people, because we actually do the echoes so that we can evaluate the heart. And my transplant surgeon does like to ventilate so we would be managing until.
We're struggling a little bit with that because we've got some new surgeons in who also are interested in ventilating and basically showed up and said, why do we not have an anesthesiologist in the room that can call? And we said, well, because we've been doing this way for half a decade, and you're new and didn't bother to ask. So we're still struggling on that one.
Yeah, and I would say our institution is somewhat similar. We are there, we will reintubate, but we do have a few individuals who do not want to. And we're a large enough center and we have enough people, even during the night, if we had to, it would be unlikely. But again, most of these are daytime for us, so.
Yeah. Lori, we do DCD, we don't do NRP. We're not involved at all. And the anesthesiologists are not involved at all in any part of the process. Please.
Rich Woolman, I'm a retired cardiac anesthesiologist from the University of Wisconsin. I've also was sitting on the ethics committee from 2000 as a faculty member. Now I'm the community member. There's no difference except, they don't have to ask a question to somebody in the community who doesn't know what the hell they're talking about. I also was one of the authors on the ASA's first statement on DCD and on the second one. And in the first one, we said that anesthesiologists are not involved, and some anesthesiologists objected to this because they said you're restricting our practice. We made it clear in this revision that the person who withdraws care cannot be involved with transplant.
Yes.
So the next question that comes up is, can the ICU people will withdraw care? If the patient has to be reintubated, can the anesthesiologist who's going to be involved in the transplant reintubate the donor, who is a deceased person, so they have no interests? And therefore, we felt that was ethically sound.
Yes.
The question,
We lost
lights went out.
We lost lights, right? So, I don't know, you said something, Rich.
The
You
one
got the
thing,
lights out.
my one question I had, going back to the beginning, the definition of death was determined by the Uniform Determination of Death Act, either circulatory or brain death.
Brain death, yes.
The 2005 or 2006 American Journal of Transplantation consensus, of which some members of our ASA Committee on Ethics were involved in, they kind of gerrymandered the definition of irreversibility and permanence, and we'll recognize that. What happened is that Busick wrote an article in the New England Journal about pediatric donations in which they reanimated the heart after 75 seconds and a couple 90 seconds. And then the question blew up. So what is, do we really need a new definition of death? Because you're not going to change the dead donor rule, although nobody understands where that rule came from or who made it a rule. We are very careful. When I wrote the policy for the University of Wisconsin, I was one of many people who wrote it, that we separate the different steps. Yeah. What confused the issue was back to 2003, when the government issued the Breakthrough Collaborative because there weren't enough transplants, because they felt that the ICU folks or people taking care of the patient in the ICU really didn't have an interest in transplantation. And to get the numbers up. They had the Breakthrough Collaborative, and they said if a patient is within 24 hours of imminently dying, the institution's got to notify their OPO. And unfortunately, the firewalls that were set up, and the firewalls were first, I don't want to be resuscitated, okay? And then there was another firewall, okay? And then I want to be an organ donor. Well, the family's saying this. And then, only then, did the OPO get involved. The Breakthrough Collaborative blurred those lines. And that's where this problem kind of started.
Yes.
The article, first article, or an article in the Atlantic on NRP was written by Josh Mesrick, who's a transplant surgeon, okay? And we did not do that donation at the university. I've heard rumors that the patient went someplace else, but we didn't do it because a comment was made about how they were going to take care of the patient, and then they were going to let him die after we took the organ. So there was a question there whether it was a live donation or what, so the NRP wasn't done. And when I left, we were just starting NRP. They hadn't done one up to that date. They've done abdominal NRP for regional perfusion for years, but not thoracic.
We're not taking organs from live patients. That's what we say. I was always taught in CPR, your brain started dying after 4 or 5 minutes. So if we're clamping the vessels to the brain, and then we're starting to take organs at 2 minutes, is this brain alive? And so that's what I really struggle with, because I don't think we should be taking organs from live patients. I think that there are some lines that we should that we don't cross just because we're trying to get better organs. And this is why I think this is what led to loss of confidence by the public in organ donation as a whole, because people kept pushing and pushing and pushing until they pushed too far. And I think that we've pushed too far. That 2 minutes is at least 3 minutes too far.
Well, I think we would all agree the same thing, that none of us want to take organs from someone that's still alive. But that article for the PEDS patients, that's a separate thing, and I would like to think that that doesn't happen anymore, because don't forget that after there's the declaration of death, you still have to wait 5 minutes. There is this so-called standoff, no touch period or whatever. No one is allowed to do anything until that 5-minute mark. And that is because there have been studies showing that if you're going to auto-resuscitate, meaning come back to life, it happens within 5 minutes. So, what you're saying, CPR and the 4 minutes, 5 minutes, that should happen within that no-touch period. Does that
Right,
make
but
sense?
there are no touch periods of 2 minutes, including in the organization that I just retired from in July.
In fact, our place is a 2-minute.
Exactly. And death is a process. Legally, we've arbitrarily set cessation of cardiac and circulation as one definition, and total brain death, which I don't think that we necessarily always observe, because people aren't doing secondary tests of brain death. That we're just doing it on clinical an exam. That we always observe it, but death is a process, and I think that we've pushed that process too close, and not just too close, but over the line. That's all.
Thank you. Anyone else?
Hey, good afternoon. Thomas Powell from Texas Heart Institute, where we don't have NRP. I was reading one of those articles, I can't remember which one, but it was available to the lay public over the summer, and it seemed to imply that the OPOs had some ability to exercise bias or influence some of these things. Obviously, there's stakeholders in all this, even though they may be nonprofit. But has that been your experience at all? Do you feel any influence from the OPOs?
Not my OPO, but even just talking about things like triggers. In fact, one of the OPOs wants to be told anytime a trauma patient comes in the ER intubated. That is their trigger. Not that they're going to talk to the family, but just to be aware of that patient. And there's different triggers by different OPOs. And part of the problem with the University of Miami is that they were doing things, pushing for donors that they shouldn't, or contacting them when they shouldn't be. And that's why the Health and Human Services are going through and looking at each OPO to see what's going on with it. Anytime any OPO showed up in my OR, I went over there and asked. In fact, there's some OPOs that won't even bother with NRP either ethically or financially because it costs a lot of money to do the NRP.
Hi, my name's David Daly. I'm from Melbourne in Australia. I just sort of throw in a few of the differences
Please,
what we do
yeah,
because they
please.
come right into this
I
argument.
didn't mean to leave off Asia and Australia as continents, but I
wasn't
said Europe, but I
wasn't offended.
should have been inclusive of all of our.
To give you the broad picture, Australia does about 200 lung transplants a year. I'm a cardiothoracic anaesthetist. We do about 100 of them at my hospital, and about a third are DCD, and we don't. None of the centres do NRP. Mm-hmm. So withdrawal of care occurs in the intensive care unit, not in the operating theatres. And the two teams, the management of the patient, the transplant team, never attend the patient before death is certified. We had a 5-minute standoff, which is problematical for the liver teams when we've got a 5-minute standoff and then transfer from ICU to the operating room. And for every single lung case, a cardiothoracic anaesthetist reintubates the patient, and we've had no opposition to that whatsoever. So, and I think that notion of in Florida of the treating team leaving before death's declared, it's absolutely their responsibility. But so I don't know, some of those things are a little bit different. I'm not saying they're better; they're just different, and the ethics change a little bit.
Well, I think also the fact that you're taking them after they've passed from the ICU to the OR increases the making sure that the donor now is dead versus we have the family in the operating room when we extubate and then the donor passes and then we have only that 2 to 5 minute standoff at that point.
Yeah, so we have the surgical team scrubbed, the nursing with the trays out and everything ready to rock, and it's usually about 3 minutes from entry into the door to sternotomy.
Yeah.
And then the other issue that we've come across that just recently is the DCD, voluntary assisted dying pathways. And I wonder if that's something anyone's had an experience with. I've done one. I felt kind of weird.
I mean, I know about them. This is when people with life-altering injuries, either high spinal cord injuries or neurologic injuries like ACLS, have decided they're done and they want to donate their organs. So they participate in their own CMO and donation. We have not had any of those patients yet, but they are out there.
Yeah, we haven't had any at our institution either, but I've heard of the cases happening where young, otherwise, healthy people have, severe high spinal cord injuries and they to withdraw care and donate their organs. And then you have someone who's completely neurologically intact, which obviously brings up other questions, but we have not had that in our institution.
And we're not even doing NRP, so that's way down on my list. I just want to, as we're wrapping up, first of all, thank you all. It's been really great. But as we're wrapping up, impact of this conversation. So we are a 100 and something lung a year center. So mid to large size center. And we're about 50 hearts, 40 to 50 hearts a year, about 110, 120 livers a year, and however many kidneys. And since this conversation started and some of these articles were published, our numbers have plummeted. I don't know how everybody else's, what their experience have been, but we did not do one lung in September, which is the first time in recent history, at least, that we haven't done a lung transplant. So,
Gave them all
we're being impacted by this conversation significantly. Same thing with our livers. We went, we're a 10 to 12 liver a month place, and we're, I think, 2 at the very end of the month, last month. So we're being impacted as an institution, and I the point of this is not us; it's really the patients, right? So now you've got, if DCD, 7,280 DCD donors last year, 43% of the donor population was DCD, and if this conversation around all of it, the DCD considerations, the NRP considerations, the ethical issues, is a lasting conversation without some I don't know if resolution is the right word, but there's a potential here to really impact our patients, not just for a month, but for a long time to come, because that population is not getting smaller in terms of, those who need transplant. So I think that's I don't know, obviously, Teresa, you didn't feel the same impact we did, but I don't know, Bruce or Jenny, how you guys felt, or anybody in the audience, but it had a big, our surgeons are stressed, they are unhappy about all of this conversation and how it's impacted our hospital, at least, and most importantly, our patients. And I just want to bring it back to the patients, because there's the donor part, but there's also the recipient part. And if we lose half of this donor pool, the impact is going to be tremendous on that population of patients.
And on a good day for lungs, only 20% of the donors can actually donate their lungs. So if we decrease, we just have a very active DCD donation, and a very active surgeons will take DCD organs. So we are always there waiting to see if there's going to be a transplant or not. And in fact, I asked my OPO, we had 300 potential DCD donations, and about 25 of them did not pass. So, I mean, we have very strict rules to make sure that donors or patients are dead before they donate, and that we also have very strict rules of who's doing what and when.
Yeah, since the New York Times article came out in July, our transplant numbers have definitely decreased. We're still doing transplants, but we have all noticed that we're not as busy as we were, say, last year around the same time.
Yeah.
Yep, and I would agree. We've seen the same thing, just we're still doing transplants, but our volume has decreased in the last couple months.
Well, if you go to that slide, a few slides back, you can actually see how many thousands of people.
I thought I tried to find.
Yep, one more forward. You can see how many people have taken themselves off the donation list.
Yeah.
Oh,
Oh, yes, sorry, yeah. It says, Donate Life America, a nonprofit that manages a national registry, has recorded a 700% increase in donor registration removals since the July 20th articles, with an average of 412 per day, compared to an average of 52 per day a week earlier. Go ahead, please, yeah, go ahead. Yeah.
Interesting question will be, though, taking your name off of the donor registry is not the same thing as not becoming.
It's not becoming a donor, yeah.
And we've seen that. I mean, I've taken my name off registry, not because of that organ or because of that article, but because of the way current laws regarding donor registry are being interpreted in relation to consent in DCD. There is a problem. We have a series of laws across the United States that were written at a time where almost every donor was brain dead. and was a little bit easier to package. And now we're seeing our OPOs show up and say, hey, you guys talked to this family about removing life support. They're a signed donor, they belong to us. And we're getting into horrible ethical grounds with that. We're still getting a lot of donors, even with having been one of the states that had a big
Yeah.
exodus off. So
Yeah.
I think the question will be,
Michigan
do
too.
we
Yeah.
see removal from donor list equate to not-
Decrease in organ, yeah, yeah, interesting, yeah.
Our institution had a very similar experience with our OPOs getting really pushy.
Yeah.
To the point that there were like near violent confrontations in the hallways, like it got very, very dark.
CMS's drive for more organ donation
It really
is
pushed
really
them in a bad
hurting.
way. And
Yeah.
we kind of righted the ship, but we had a tremendous number of people do exactly what you're describing, to take themselves off the registry, not necessarily to avoid being an organ donor, but to give the power back
To their families in that situation, yeah.
so that these gift laws that preside over organ gifting would be applicable.
Interesting, yeah.
And that's why we're doing, that's why all the OPOs are being evaluated now.
Yeah. Okay, well, unfortunately, time, and I'm getting the high sign from the back of the room. So thank you all for your participation. Thank you to the panelists. Thank you to the ASA. And we're going to lobby for part 2 next year.